Next, we have a panel discussion regarding dealing with the challenges in management of childhood lupus. I would like to request Dr. Amita Aggarwal, ma'am, Professor and Head of Department of Clinical Immunology and Rheumatology at Sanjay Gandhi Postgraduate Institute, Lucknow, to moderate the session.
Good afternoon, friends. We have three panelists, Anand, Sujata, and Rakesh. So Rakesh, you have to come back again. Maybe he's gone to the restroom after his presentation. And what I have planned is that we will have a 30-minute interaction with the panelist and 20 minutes with the audience. So we are going to distribute you these slips. Please write your question and send back to me. And we'll take up questions. 20 minutes are all for audience. So if you can distribute to the audience, write your name and a short, crisp question. If I get more questions from you, then we will decrease the time for the questions which we have prepared, because we want you to interact. This session is only for the audience. And what I have done is I have restricted the session only to the treatment issues. We are not discussing diagnostic issues in lupus, neither are we discussing social issues at this time, which I think Rakesh has highlighted some of them. So can we start the presentation? So this is, I feel lupus is a challenge every day, and saying that challenges in management is an understatement. We were supposed to have other panelists, and because of the scare of the cyclone, I must thank Sujata and Rakesh to agree at the last minute to be part of this panel. So first question to Rakesh. You have answered some of it in your previous presentation. So we have this girl, 15-year-old girl, who's found to be ANA positive when she had fever lasting for 2 weeks. Her mother has lupus for the last 5 years. The family has come to you. What should we do for her? So what are your thoughts?
So, thank you, ma'am. So, basically we are dealing with an adolescent girl who is having fever and then ANA positivity. So I'll go with inquire about the more history regarding that. What is the presentation more than fever? Then if ANA positivity is just a ANA titers and all these things, and then I'll go if there is organ involvement related to that. If we are, I'm thinking
she has nothing else. She just had a fever which lasted for 2 weeks, and at present she's asymptomatic.
So basically, if ANA positivity and then the type of ANA immunofluorescence, and then if it is just ANA 1 plus or ANA ELISA titer which is less than 160, possibly I'll just follow her, and maybe if their ANA positivity is a strong ANA positivity with 4 plus pattern or some like immunofluorescence pattern which suggests, then I will be worried for that, and then I'll work up her more for the lupus organ manifestation.
Okay, Sujata, would you do some more tests? Or that's enough?
No, I would look more carefully at the ENA profile in this patient. I'd look at complements, look at urine, take the blood pressure, and I'd be concerned whether this is a complement deficient family, where the mother has lupus and now the child has. So that would be my approach.
Okay, so I think the audience have got the gist that take a good history, do a good exam, see for hypertension, do simple tests, don't do complicated tests. If complete blood count is normal, urine is normal, patient has no hypertension, no clinical features, just allay the fear. Be under follow-up, that's it. Second, so you have this 10-year-old girl who had rapidly progressive renal failure, has lymphopenia, mild anemia, ANA is 4 plus homogeneous, high anti-DSD titers, low complements, thought to have lupus-related rapidly progressive renal failure. So Anand, what will be your first line immunosuppressive therapy and why?
Since it's a rapidly progressive renal failure in a child with all features of lupus, this child would require therapy which acts fast and prevents progression to a acute kidney injury or acute renal failure, which can subsequently cause.
She already has renal failure. She has rapidly progressive renal failure.
So I would use cyclophosphamide with methylprednisolone as my first line therapy,
Okay.
to deal with the very rapid
Okay,
hurtling
so your
disease.
choice is methylprednisolone along with cyclophosphamide. Sujata, any different?
I would be bold enough to add rituximab here.
You will use rituximab. Rakesh?
So I'll agree with Prof. Anand Rao that I'll start with methylpred pulse and then cyclophosphamide in this. But at this age, in this age, there will be some hindrance about that, because you have a next question about the gonadal toxicity.
We'll come to that. We'll come to
yeah.
that. So,
But
we have
at the
vote.
start, because that is the life-threatening part, and I would use methylpred pulse and cyclo.
So we have 2-on-3 vote for cyclophosphamide and 1-on-3 for rituximab. So let's have the audience poll. How many of you would use cyclophosphamide? Oh, almost 90%. Maybe it's an access issue. You can either use either of them. Because if you see management of rapidly progressive renal failure, once you're given methylpred, you can either use rituximab to reduce your B cell, your antibodies down, or you can use cyclophosphamide, which also depletes the B cells and the T cells. So the choices depend on the cost and many other factors. So the second question is, the two people who chose to use cyclophosphamide, what is the evidence for gonadal toxicity in children?
Gonadal toxicity in a prepubertal girl or a peripubertal girl tends to be much, much lesser as compared to a older adolescent or an adult female. So the ovaries, because they are not mature or not producing follicles, the risk of gonadal toxicity is much lesser.
So much less means less than 5%, less than 1%, or 0?
I think it's less than 5%.
Less than 5%. Rakesh, what's your take?
So basically, the data on the gonadal toxicity is basically, I feel that there is not much data, ma'am, because that is a problem with this. But in our experience, whenever we are using in prepubertal children, like now these kids are like now they are in 30s, few of them are that they are married and they have children. And what we are doing in the prepubertal or pubertal is that we are using GnRH agonist. So as to just to suppress the puberty at that stage, and we have started using GnRH agonist in these settings, and probably whether that make difference, we still don't know, because that is long way to go.
Okay, so this is a very recent meta-analysis which has come in August 24 this year. And if you see at the end of it, this review suggested that cyclophosphamide use in childhood may not conclusively have any significant effect on ovarian function, even though they showed that there was a trend towards having higher FSH level, which also suggests subclinical ovarian toxicity, but it's not very significant. So if you are against the wall, you can definitely use cyclophosphamide. Don't be scared if it is needed. Challenge 3. This is for Sujata. Sujata, what is the dose of IV methylprednisolone which you use in these kind of severe lupus, rapidly progressive renal failure, diffuse alveolar hemorrhage, or patients with macrophage activation syndrome? What is the dosage you three of you use?
So, in a very sick lupus patient, we may use maximum of 1 gram. But if the patient is moderately sick,
Now we are talking of severe. Severe lupus.
in a severe lupus, we will go up to maximum 1 gram,
30 milligram per kg.
stopping at 1 gram.
Stopping at 1 gram. Rakesh?
Yeah, I agree with ma'am that I'll use 30 milligram per kilo in most of the settings of severe lupus and 3 to 5 days.
Anand?
We have started using a lesser dosage now. We use about 10 mg per kg.
Okay.
Partly because of your teaching, you say that non-genomic actions,
Okay.
they flatten out after 10 mg per kg per dose of methylprednisolone. That's why we have been using much lesser doses of
So do you find any difference?
I think the effects seem to be the same.
Okay. So this is in acute transplant rejection. You can't have any situation worse than that you will lose your kidney graft. There people have shown using 3 milligram per kg versus 15 milligram per kg, there is no difference at all in acute transplant cellular rejection. If you see this, there's a very beautiful editorial, even though it's pretty old, that methylprednisolone therapy for acute rejection, too much of a good thing. Do we really need to use too much? And it's based on evidence that beyond 200 milligrams, there is nothing what you gain except the side effects. And if you see the latest EULAR guidelines, they have advocated using from 125 to 1000 milligrams because they still haven't come down to that level. Rheumatologists use a much higher dose of methylpred boluses as compared to nephrologists. Most of their transplant rejections now, they have come down to around 125 to 250 milligrams. And I don't think lupus flares are worse than a cellular transplant rejection. So we need to cut down our steroids, which give you significant toxicity. And you're not achieving anything great by giving those mega doses of methylpred boluses. I mean, just a food for thought for you people. Because pediatricians, I find, use much higher doses than adult physicians, definitely. Okay, so this is another challenge. Maybe, Anand, you can take it. 11-year-old girl with fever, rash, oral ulcers, cytopenias, diagnosed as lupus. She was started on 1 milligram per kg prednisolone, hydroxychloroquine. She developed altered sensorium, purposeless laughing, became unresponsive with vacant stare. And she was not obeying commands. She had waxy flexibility. So she was diagnosed as psychosis somewhere outside. But they had given her haloperidol. She had no response at all. What do you think is a likely problem in her?
What started off as with the constitutional features and hematological lupus, as subsequently there is a neuropsychiatric manifestation. What looks like an acute confusional state, which is going on to maybe psychosis.
So the psychosis, yeah.
So this is a manifestation of the CNS lupus. So the progression is indicating that from a moderate disease or maybe a mild disease, it's progressing on to moderate and severe disease over a period of time.
So anybody has any other thoughts? Sujata, anything else you want to add? Why is her psychosis not responding to haloperidol?
Maybe developing
That's the clue from there.
some basal ganglia involvement.
Basal ganglia involvement. So actually what she had was catatonia. So when you get catatonia, if looks like psychosis, I showed you that she had a waxy flexibility. You put their limb like that, it will stay like that. It will take a long time to come down. If you examine patients who don't respond to the standard antipsychotic drugs, must look for catatonia. Because catatonia treatment is totally different. You need to treat with lorazepam. So when she came to us, when we examined, we thought it looked like catatonia. Extremely rare in lupus. Her everything was normal. CS exam was normal, MRI was normal. And she, on top of it, she developed macrophage activation syndrome. She was treated for mass. She started, everything else improved, but her catatonia was not improving, even though she was on lorazepam. We kept on increasing the dose of lorazepam, 2 milligram 3 times a day. Still she didn't improve. Finally, she had to get ECTs. And then she also got rituximab, doing all the works for her management of lupus. And gradually over time, you see her. She's perfectly well. And now it's 4 years follow-up. She's absolutely good at school. She's topping in her class. So despite the ECT, she doesn't, at least at this time, does not have any cognitive dysfunction or anything. So recognizing catatonia is a very important thing. Don't label it as psychosis and keep on giving antipsychotic drugs. Okay, Rakesh, you want to take this case? And these are all challenges of management which we have. So this is an 18-year-old girl who had lupus, diagnosed about 3-4 months ago. She had abdominal pain and diarrhea for 15 days. And you have her X-ray here and a CT, part of the CT film which is provided to you. What do you think she has and what will be your approach to management?
So basically, ma'am, the case highlight the present lupus enteritis presentation, and possibly that is the one of the under-recognized and one of the severest manifestation of lupus, because we don't recognize very early, and probably we also have our fears here, and with that children come with the simple diarrhea and we miss that maybe that is infective diarrhea or simple viral diarrhea, but this presentation should be kept in mind that it can be a lupus enteritis, and these patients should be worked up, and this is and these patients can go on to develop the perforation if untreated.
Yeah. So you can see here, whole of the bowel is dilated. is involved. And this is a very typical sign. You can see the increased mesentery, vessels in the mesentery, accordion sign or whatever you call it, and bowel wall edema. It's the most difficult thing to treat. So Sujata, how would you treat her? What will you give her?
So this patient we will treat with intravenous steroid. We will give a broad spectrum antibiotic and we'll give a cyclophosphamide. And if possible, we would add rituximab for these patients. We've recently had this patient who had a very stormy course, and it becomes a very difficult decision whether you want to intervene surgically or not. You really have to tie your hands behind your back, and until they develop a perforation, prevent them from going to surgery. But it's very challenging, extremely challenging.
Yes. Anand, anything about chronic enteritis? This is an acute enteritis. What about chronic enteritis?
I think everything has been answered, nothing more from my side.
And chronic enteritis is even more difficult. When those patients just have weight loss, diarrhea, they would be referred to you to rule out immune deficiency actually, because they are having chronic diarrhea. And when you investigate and you take history, then you find they have thrombocytopenia or something else, and you can diagnose them as lupus. Some of them require even TPN for long times before their chronic enteritis is more difficult to treat. The other thing which you can pick up in ICUs is bilateral hydronephrosis, hydroureter. And they would be calling the urologist. And the urologist would say there are no stone, nothing. And actually that is all manifestation of involvement of the mucosa of the urinary tract, which gives you bilateral hydronephrosis and hydroureter. So that can itself be a manifestation of enteritis along with it. So this is the data which we have of our cohort. I'll just show you how much of enteritis we saw. This is 2,503 patients of lupus, both adult and pediatric together. 41 of them had enteritis. So it's not an uncommon manifestation. And it can be associated with pancreatitis also in the same go. So that both of them, when both are there, it's even more challenging. So the chance of perforation and all becomes really more. Okay, this is the question which every mother has who brings the child to you. When will the steroid dose reduce? So Anand, how to reduce steroid exposure to children? One, we have talked of methylpred bolus.
Apart from using low dose pulse steroids, try to reduce the dose of steroids as soon as possible within the first 3 to 6 months to less than 5 mg of adult equivalent if the disease is mild. But it might be prudent to sometimes use, or many times, to use a steroid sparing immunosuppressant agent. We tend to use mycophenolate or methotrexate depending on what is the other extrarenal manifestation in these patients to reduce the dose of steroid and bring it to the lowest dose possible. And if possible, earlier the thought process of steroid should not be stopped. But that thought process has gone out of the window. Now we are looking at stopping steroids as soon as possible when the disease is under check under the cover of an additional immunosuppressant agent which is steroid sparing.
So when does your child come down to 5 milligram who's been started induction on lupus nephritis? At 3 months, 6 months, 9 months, 12 months?
If it is a
garden variety, lupus nephritis.
Lupus nephritis? No, lupus nephritis we try to bring it down to 5 by about 6 months.
6 months. Sujata?
No, we generally take about 10 to 12 months to get it
10 to
down
12
5
months. Rakesh?
Yeah, same. That basically it took us around 9 to 12 months. Anywhere between 9 to 12 months, we will reach about 5 milligram. And so, because lupus, and specifically in the proliferative, the garden variety, lupus 5, 4, 3 and 5.
Okay, let's see. So actually, if you see, the initial glucocorticoid dose is one of the predictors of overall glucocorticoid exposure which a patient is going to get. If we start with 1 milligram per kg, we will take a longer time to come down. Better to start with 0.5 milligram per kg after you have given the methylpred bolus. So that would reduce their exposure and chance that they would come down faster. And so if you see our patients, so this is data on pediatric lupus of 491 patients from that cohort. We could get down to less than 7.5 in 70% by 12 months. I mean, this is from 10 centers in India. Ours is even faster. We go to 5 milligram by 3 months and 5 milligram by 3 to 4 months and 2.5 milligram by 1 year, and generally off by 1.5 years. We try to cut down steroids exposure very much. And we have found that there is no difference. I've been treating lupus for 40 years. We used to treat with loads and loads of steroids. But if you use immunosuppressive therapy judiciously, escalate their mycophenolate, add some other immunosuppressive agent, you can add tacrolimus to it, but you can definitely cut down the prednisolone dosage. So that makes the child to grow. The growth is the most important thing which gets affected, and that has a lot of social impact on the child, especially if we keep on giving higher doses. But probably 5 milligram is okay, even if we give it for longer period of time. And the best is this trial, voclosporin trial, which was done for lupus nephritis, and you see what proportion of patients, 87% of patients are on less than 2.5 by 12 months, and same percentage continues. So you can reduce to that lesser dose in patients with severe lupus nephritis. Okay. When will you stop immunosuppression? Yes.
May I interject there?
Sure.
So typically we would today say that at least in an adult patient you want to get down to 800 milligram of proteinuria by the end of 1 year.
Yes.
That's the target. That's the target. That's been increased. So if your patient at say 7 or 8 months on 10 milligram steroid or 7.5 steroid is nowhere near that target, it's very difficult to get the steroid down. And then if you're going to add a second layer of tacrolimus, first of all, that's an added cost. That increases the immunosuppression. We may be being very aggressive by adding a second drug, and then TAC has its own toxicity. You don't want to continue it for a very prolonged time. So it's a very nuanced decision.
Yeah.
How do you want to reduce steroid if
Absolutely.
you're looking at the objective disease activity of the patient and your patient is not going into remission?
Yeah, so lupus is a disease where it's absolutely individualized. There would be a patient who cannot afford tacrolimus. You might like to continue on corticosteroids, but the attempt should be to get down prednisolone dose as much as possible. And tacrolimus is not a bad drug. You can cut down the mycophenolate to 1 gram, add tacrolimus. That will control your proteinuria much better than hiking up the dose of steroids. Because tacrolimus itself has a podocyte effect, reduces the proteinuria. So that gives you much better control if there is only a pure proteinuria, rather than having higher doses of corticosteroids. Okay, the question which is on all of our mind, when will we stop immunosuppression in a child who is in remission? How long should the child be in remission when you start tapering off or stopping immunosuppression? Anand?
So if you're talking in terms of lupus nephritis,
Yeah, lupus nephritis, other forms of severe disease, enteritis, neuropsychiatric lupus.
the first thing we try to stop is the steroid. We
Okay.
tend to continue with a drug like mycophenolate at least for 3 to 5 years after initiating it. That's the usual duration. We normally tend to continue it for 3 to 4 years from the first time of initiation. Make sure that the child is under good remission without any evidence of with SLEDAI scores being 0 persistently. So that's what we aim for. In the other cases also, at least couple of years extra renal, wherein there is no lupus nephritis, a couple of years of disease control, continue with hydroxychloroquine, continue sun protection, maintain the ideal weight, make sure that the body weight is maintained well, and so maybe a couple of years while we continue to monitor for new onset proteinuria or any extra renal
obviously. If
manifestation.
there's a relapse in between, you won't. Then the child is not in remission. We are talking of continuous remission.
Extra renal earlier, renal we tend to
3 years or 5 years.
3 to 4, 3 to
3
5.
to 4 years. Sujata?
For renal lupus, we will stop medication after 5 years, and for other conditions, maybe between 18 to 24 months, depending upon what the patient had. But we don't take off hydroxychloroquine until the rare patient becomes ANA negative.
ANA. Do you test ANA again?
After 10 years, yes.
10 years, okay.
Yeah, that is a very difficult question, ma'am. Like basically, when it is easy to answer in here, but it is difficult to answer in clinics. When we are dealing with patients, like now with major organ involvement, especially lupus nephritis, psychiatric manifestation, like CNS manifestation and other major organ manifestation, we will continue at least for 4 to 5 years in these patients after remission, and possibly like, and after that also, sometimes it's difficult in few patients, like which Dr. Anand has also highlighted, that when they are flaring, but usually 4 to 5 years
Yeah, it's
is
best to
something which
taper
we
off than to stop suddenly. So it's best to come down the dose, half the dose, and monitor
something
for
like
3 to
when
5
they,
months.
which something like with, when they grow that on same dose, the dose titration is like not there actually.
Okay. So can we have the questions? Can you give me the papers? Okay. We can, but we would like your questions. I have many more questions, but okay. First question is from Suma. Cyclophosphamide in a young adolescent male, more toxic in teenage boy than teenage girl. How many of you agree to this statement? Yes or no? Cyclophosphamide is more toxic in teenage boy than teenage girl. Anand, you agree or not? Yes or no? Just that. No. So, more toxic in teenage boy than teenage girl. Yes or no? No, you have to only say yes and no. No way, you can't go anywhere. Girl. Yes and no?
Reported more in boys.
More toxic in boys? Rakesh?
Don't know.
Don't know. Good. So it is definitely more toxic in boys. The incidence of azoospermia is much higher than what you find ovarian toxicity. So you need to be very careful in boys. Fortunately, we see less boys having lupus. Okay, let's have more questions. But still. But that is the data. The data suggests males develop more azoospermia than ovarian failure in females. Okay, we don't have the name of this person. Somebody is asking, ideal MMF dose and how frequently monitor drug levels. Sujata, you must be doing drug levels. What is the ideal MMF dose and how frequently do you monitor mycophenolate levels? You can give me more.
We don't monitor mycophenolate drug levels. I don't think we have the facility to do that. But we would use 625 milligram per meter square per dose, given twice a day, or in a younger child, 55 milligram per kg per day, total dose divided in 2.
So the second question from the same person is how to manage post-rituximab hypogammaglobulinemia. Have you seen it? Yeah, Anand? And how do you manage that?
Yeah, I've seen it in a couple of patients. When you have a post-rituximab hypogammaglobulinemia, you can give IVIG if it is a significant hypogammaglobulinemia. Marginally low you would expect, but if it is significant, and just before the next, if you are planning another dose of rituximab a few months later, you should give IVIG and then plan rituximab.
So it's not that it is not heard of, it happens, especially when you use multiple doses of rituximab. If it happens, either you change your therapy or you give IVIG prior to giving rituximab therapy.
So prior to rituximab therapy, like whenever we are using the rituximab therapy, it should be like done immunoglobulin profile and
Yes.
B cell subset before the starting rituximab.
Absolutely.
That should be the, and then we should monitor these patients, and possibly use of intravenous immunoglobulins or antimicrobial prophylaxis will depends on the infections and
Absolutely.
immunoglobulin levels. So because sometimes rituximab induced hypogamma can be underlying something.
No,
other
do
than
not
just-
start before testing, because children can have immune deficiency at the baseline. So must do baseline levels before you start retux.
Madam, one question for you
Yes, sure.
before you
For
shoot
me?
the next
Okay.
one. When we are in
What?
rituximab, have you seen rituximab-induced leukopenia?
Yeah. You see rituximab-induced neutropenia, you induce rituximab-induced leukopenia. Those are well known.
And the cutoff for the IVIG is 400 milligram per deciliter.
Yeah.
If it's less than 400, you should substitute and then give rituximab.
Yeah, but even if it is more than 400, between 400 to 600, if the child has infection,
Sure.
you should give IVIG before giving. So this is an interesting question. Management of steroid-resistant pericardial or pleural effusion. Pericarditis or pericardial effusion. Rakesh, you want to take that? How do you manage corticosteroid-resistant pericarditis?
Anakinra.
You want to take it?
I don't have an experience in this regard, so basically it's more of theoretical. So
You can pass on to
so
Anand.
if it is a massive pericardial effusion, something like that, that can be like manifestation of like maybe we have to see the other organ manifestation also. If it is isolated thing, so possibly just some like something like we may be using that other therapies. Hydroxychloroquine has also worked in these settings, and colchicine sometimes can be
Yes.
can be tried.
Absolutely. Oh, that's so many questions coming. You want to add anything, Anand?
No, you would add on the steroid sparing agent, mycophenolate cyclophosphamide will work because apart from serositis, there will be some other manifestation which also indicates that there is a disease activity.
Yeah, if the child has no other manifestation and is having recurrent pericardial effusion, you can even just make a pericardial window. That sometimes helps. We have done it in one patient. That patient used to always come with pericardial tamponade 3 times. Finally, we convinced that girl that you need to get a window. So you can use colchicine, you can use other immunosuppressive agents.
Azathioprine works, colchicine
Absolutely.
works.
Let's take some more interesting ones. What is the longevity? So they are talking of survival. What is the longevity of a child with lupus without treatment? Has anybody of us not treated lupus and with the best treatment? So if you don't treat, like historical controls versus the best treatment possible today. Who wants to take it? Maybe I am the oldie in this generation. So if you don't treat, what you people had shown earlier, that the survival before the corticosteroid era was in the first 2 years, patients with lupus nephritis, almost 70 to 80% would die. I mean, we are talking of proliferative nephritis. We are not talking of the just class 1, class 2 years proteinuria. But if the patient had clinically manifest lupus nephritis, almost 70% would die. So that was the survival at that time. And now, you want to take, what are the figures now, Anand?
I think in the best of places, I think the mortality is 5% or lesser than at 10 years.
Yeah. So there is a clear divide between boys and girls. Boys do worse than girls. And in developed countries versus developing countries. There's very good data. I have the figures if you want to see at the end. That in the developed world, the mortality at 10 years is about 5 to 7%. In lupus nephritis, it's about 10 to 12%. While in developing countries, it is at least 7 to 10% lower. I mean, 7 to 10% mortality is higher, so survival is lower. And our data also suggests the same. That when you do retrospective studies, it looks very hunky-dory. When you do prospective studies, then you really realize, when you account for each person. So what we have seen in this cohort, where we had these 491 patients, children with lupus, is 82%. Partly it's vitiated by COVID pandemic, which happened in between for 2 years, poor access to therapy, but it is not that great. Okay.
Yeah, ma'am. Even in our cohort, the mortality is 20%,
Yeah,
so which is a significantly higher.
So this is by Niranjan Mohanty. What are the factors or parameters should be focused to reduce mortality? Sujata, you want to add 2
So
or 3?
I think one thing that gives rise to increased mortality is increased use of steroids. The second thing is the patient who is not adherent. The third thing is not doing simple measures like vaccination. And the fourth thing is not knowing your beans.
Okay.
So in our cohort, like the major, 2 major cause of mortality was breakthrough infections and the severe disease activity at the onset, and possibly in long run, basically the vaccination, which is a very important factor. So we have to vaccinate these children for the specifically.
I think the biggest hindrance or the biggest cause of mortality in our setting is loss to follow up. Those patients who don't follow up regularly or don't take treatments regularly, lack of adherence to therapy, they tend to have very high mortality.
Actually, infection is a very important cause of mortality in our population. So it occurs, severe infections occur in this data which we have for 225 patients, 20% of them had really severe infection. So this is Rakesh to you. You had shown that patient who had C1q deficiency had high type 1 interferon signature. So Girish is saying, should we use JAK inhibitors upfront in those patients?
So Basically, there is a nice paper in JASI in practice on use of baricitinib in patients with C1q deficiency lupus, and they have shown effect on. And so, why like C1q deficiency lupus is a special, because you can think of transplanting these patients, but transplant outcome in these settings is not very great actually. And Sagar is not here, but he has done one transplant in one patient, but ultimately has not succeeded. And we have also 6 patients with C1q deficiency lupus, and we are also contemplating that we are trying them on plasma infusions and steroids and MMF, but possibly in these patients the role of JAK inhibitors is there, and the new data suggesting that interferon, it looks like an interferonopathy, so possibly we can use this.
Yeah, so you can use in like this child which Sagar had, he had presented ACP5 mutations. There you use tofacitinib. It works very well. So probably it will be partly useful in patients with C1q, but they have high risk of infection. So that is a real worrisome. So another person is asking that case which we presented, RPRF, rapidly progressive renal failure. What is the role of plasmapheresis? Anand, in those situations,
After usage of methylprednisolone and maybe cyclophosphamide, if the improvement is not seen and the child continues to deteriorate, then yes, plasmapheresis can definitely be used to take out the pathogenic antibodies from the circulation.
So anybody else, Sujata, have you used plasmapheresis ever besides TTP? TTP is a treatment of choice, but otherwise,
We have not used plasmapheresis in our lupus patients.
so a randomized controlled trial in lupus did not show any benefit of using plasmapheresis, but as a desperate measure, sometimes we use it when we are against the wall and nothing is helping, creatinine is rising up. So the nephrologist would say, okay, let's give it a try. So this is another question on the same by Dr. Archana, and she is asking what should be the timing of renal biopsy in a patient who has rapidly progressive renal failure and lupus. So when will you do?
So whenever we are dealing with RPRF in lupus, the treatment precedent or the biopsy timing. So we have to treat these patients. We have to manage them. Whenever they are stable, we can do renal biopsy, because it's like a few doses of steroids and like a dose of cyclophosphamide will not change the finding in much, because during that time there are several issues, like you cannot do renal biopsy, and possibly in in 2 weeks or 3 weeks we can do renal biopsy, and we are doing like that in
Absolutely.
our setups.
You have to dialyze the patient, stabilize the patient, because otherwise there is an increased risk of bleeding. So you want to stabilize the patient before you do renal biopsy. And invariably you are going to find crescentic glomerulonephritis. So the biopsy actually doesn't add much if you are absolutely sure that it is lupus related rapidly progressive renal failure. So the next question, the name is not written, that why does psychosis with catatonia does not respond to steroids, and how is the SLE associated catatonia different from other psychosis? It's most important to recognize catatonia. That if you find that waxy flexibility, you must examine the patient with psychosis. That's the only the thing is. And if you find that and the child is not responding to conventional antipsychotic drug, think of catatonia. There you need to give lorazepam, other drugs don't work. And you need to gradually escalate the dose of lorazepam. That's a lesson we learned from this patient. And after that, we have seen 2 more patients where we treated very early. And the child, both the patients responded. It's much more common in children. Catatonia is much more common in children as compared to adult lupus. And they responded beautifully just with 2 milligram or to 4 milligram dose, and both children catatonia recovered.
So Amita, this slide you put up here, in our series we saw that herpes zoster was the commonest
So
infection.
in this, we have excluded herpes zoster.
You've excluded.
So this is only serious infection. Okay. So we haven't taken herpes zoster, skin fungal infections, the usual ones. These are serious infections. Okay. So this is question by, sometimes difficult to read handwritings. Child with lupus on treatment, so possibly talking of serologically active, clinically inactive lupus. Clinically well, no lupus nephritis, dsDNA normal, but complement persists to be low. Will immunosuppression be increased? So do you treat labs or do you treat patients?
Always patients.
Always patients. So just follow up that patient who has low complements but everything is normal. Do a more vigil. Tell the patient that if anything goes wrong, please come early, but do not escalate immunosuppression. Okay, this is Dr. Gargi Samal. Is it lupus enteritis or GI vasculitis or both are synonymous? What do you think, Anand?
Lupus enteritis and GI vasculitis are, I think it is a GI vasculitis which is causing enteritis.
Absolutely. The pathophysiology is vasculitis, small vessel vasculitis, which presents as enteritis. Okay. Can't read. What is? Position of JAK inhibitors in lupus therapy. Anand, what do you think? What is the position of JAK inhibitors in lupus?
Still literature is coming out about usage of JAK kinase inhibitors in lupus. The place where JAK kinase might be used in those monogenic lupuses wherein there is significant interferon signature elevation. That's where there is a role for JAK kinase. In routine run-of-the-mill lupus, I think still doubtful. We have good medicines available for their treatment already.
So the randomized controlled trial with baricitinib did not reach its primary endpoint. The only trial which showed some benefit is with TYK2 inhibitors. So there are phase 2 or phase 3 studies now ongoing on TYK2 inhibitors. So this is what you said, Rakesh, use of GnRH analog. Is it mandatory to use GnRH analogs when using cyclophosphamide in pubertal and pre-pubertal adolescent? This is question by Suparna. What do you say?
Pre-pubertal adolescent, I don't think there is any need for it at all because they are already not ovulating. Only in those who are ovulating, we give them the option, and I prefer to start them off as ovo protection measure, and we continue it for the duration of use of cyclophosphamide. Normally now you use urolupus protocols for 3 months. So 3 injections or 1 depot of 11.75 is sufficient.
So Sujata, you use GnRH analogs?
And the reason for that is our restricted use of cyclophosphamide. Because we don't really cross 3 grams in these patients. And also there are reports that if in case the cycling is not done appropriately, you can worsen the ovarian outcome.
Absolutely.
So you have to be very careful about the timing of the agonist as compared to when you give CYC, and currently we are not using it.
Okay, so Girish has written that in one lecture before, it was said that NIH protocol is superior to Eurolupus protocol. Your comments. Nobody said that. Actually, if you look 10-year data of Eurolupus versus the study, they did not find any difference. There was a 1-year follow-up, there was a 5-year follow-up, 10-year follow-up. And even looking at the ovarian function, they have measured anti-Mullerian hormone and shown that Eurolupus protocol actually does not have any impact on ovarian reserve. So you can use just a low dose Eurolupus protocol. Even though we haven't validated it, but...
Madam, if I might say,
yes,
in
sure.
2023, the EULAR recommendation, in those with severe forms of lupus nephritis, I remember having read that NIH might be used for 6 months. The ones with crescents and presence
Absolutely.
of viral lesions
So
or interstitial nephritis.
People are using it because in the Eurolupus study, they did not include patients with rapidly progressive renal failure and other... So we don't have data for that group. Okay.
The data from the CARA which I have discussed, which is a recent data, and this is in childhood lupus nephritis only. So that suggests that if you use Eurolupus, then there is a similar profile.
That gives you only 3 gram exposure. So using Eurolupus is pretty good. Rituximab, this is Dr. Sulechna or Sushma. Rituximab, 6 monthly doses as maintenance in lupus nephritis, your experience. How many have you used? Are you using maintenance therapy as we use for ANCA vasculitis? Rakesh? No. Sujata?
No.
Are you using?
We have only a couple of children where we've had to use it because those children have responded only to rituximab. So those are the kids where we've gone ahead and given 3-4 infusions, 6 monthly, but as a rule, no.
In a single patient with autoimmune cytopenias, because there was lack of response to any other cytotoxic or immunosuppressant therapy, we have been using 6 monthly to 9 monthly rituximab to make sure that the platelets are well maintained.
Okay, so we have the last 1.5 minutes and we must touch infections. I had some questions. So this Person has asked, lupus with infection, TB, fungus, after treatment of infection, if no clinical features of flare, but rising ESR, cytopenia, to treat or wait?
Is after treatment of the
After
infection.
treatment of infection?
No, after treatment of
So,
infection,
I mean,
you'll have
it's
to
not
treat
very
the
clear.
disease.
The question is not very clear, but I assume that the person wanted to ask that if you have both infection and disease activity, how do you proceed?
Dr. Sujata, you want to answer?
Yes. So infection would take precedence. You have to
Absolutely.
treat the infection, lower the immunosuppressive medication to the minimum, and once you get on top of the infection, then do a slow crossover.
So it also depends which is organ threatening. If you have a mild infection and a severe disease, your precedence will be disease. If you have a severe infection and your disease activity is very mild, treat the infection fully. If you have both severe, at least give 48 hours for the anti-infective agent to work before you start any immunosuppression. So should you use GnRH agonist for boys? Have you used anybody? I haven't.
So, like now, basically, it's a it's looking the like a side effect profile. Possibly, we have to use GnRH in boys also, but it's that how like now how it would work, how it is like now, that is a possibly we don't know actually.
Yeah.
But the more
So the
ideal
best
thing,
way is
more
to
ideal
just
thing
freeze
is that
the sperms.
Yeah.
Try to preserve the sperms. So thank you. I think we have had good discussion. I'm sorry I could not take these questions, and if you want, we will discuss in the evening over dinner the rest of the questions. Thank you. Thank you for the panelists and the audience for your great participation.